Welcome. This short recording is meant to review chronic obstructive pulmonary disease for the physical therapist. This is assuming you already know what COPD is, you've had some exposure to it already. This is just meant to hit the highlights and make you think about some of the broad things we should consider when our patients come to us with obstructive disease. So here's your definition of obstructive disease. The key points here, it's usually brought on through some long-term exposure. We'll talk about those a little bit later, smoking or environmental things. And we see problems with airway flow. So there's something that happens in the airways. It can be inflammation, hyperresponsiveness. There's been some damage to the airways. That has led to this issue here in the vascular system and also the airways. What does this mean? Well, loss of elastic recoil. This is my really bad drawing of an alveoli or alveolus. What happens is we have all the elastin, which is in there, and the collagen. It's broken down over time, and we lose that recoil. So as the alveoli brings air in, there's this rebound inward that helps push the air out. Due to the damage of COPD, we lose that. We have hyperinflation of the lungs. So the lungs become hyperinflated, so our lungs might normally have a nice shape to them, kind of like this on the chest radiograph. But what happens is they become very hyperinflated, and you might think that's a good thing. You bring more air in. Well, you lose some of that elasticity, you lose that rebound, and they become hyperinflated and affect the overall mechanics of breathing. We have impaired gas exchange that takes place. So what might happen is because of all the damage to the lungs, those little O2 molecules, those little air molecules, have a harder time getting into the blood. So they have a hard time getting into the blood to allow that gas exchange to take place. And ultimately this leads to more dyspnea during activity and rest, impacting our everyday activities, impacting our ability to do the things that we want to do. Also, what we see that happens is COPD goes beyond the lungs. We have generalized weakness. There's something with the inflammatory process of COPD that negatively impacts the muscles. So we lose strength in the periphery, but also in our respiratory muscles. Cor pulmonale, or right-sided heart failure, because there's increased pressure in the lungs, the right side of the heart has to work harder to pump the blood in. So we see right-sided heart failure. Exercise intolerance. It is uncomfortable to exercise. It's painful to exercise, so we stop exercising. Nutritional deficiencies. Because it's so hard to breathe, we end up eating less, and that causes weight loss to happen. It makes it difficult to have the energy to do the things that you want. And because you're working so hard to breathe, your metabolism is higher, and you need more calories. But at the same time, it's harder to get those calories in. So it's a chain reaction. And then there's the more patient-level things that are going on, the emotional, psychological issues. It's very stressful to not be able to breathe and to worry about that, as you can imagine. If you have trouble walking up a flight of stairs or doing just basic activities, it's hard to work, and you might become disabled. So these implications of COPD carry into who we are as an individual and what we can do in society. What are some of the irritants? The big one, as you see, would be cigarette smoking. That's the biggest one here in America, and you see there's some other ones here, but cigarette smoking is the most common cause. We can break down COPD in a couple different classifications. The first is emphysema. During normal healthy lungs, our alveoli are very small, which provides for a very nice large cross-sectional area, and that puts all the little air molecules, oxygen molecules that are in the lungs, if they're floating here or here or here, the distance they have to go for gas exchange is pretty small. So that's an advantage of our lungs. What happens with emphysema is these airways become enlarged, and while the sacs are bigger, which you might think is a good thing, actually it's not, because now the air molecules are here, and they have this much further to go to get out to that blood supply for that gas exchange to take place so the oxygen can be delivered to the periphery. Also, what we see with emphysema is breakdown of the respiratory bronchioles and alveoli, and we lose some of that elastic recoil as mentioned before. The airways become dilated, we have air trappings, residual volumes go up. This is where we see those big changes in pulmonary function testing. The diaphragm becomes flattened. Normally our diaphragm's a nice dome shape is what we see, and that's a good thing, so it lines up with our lungs, and then we can use that diaphragm to move downward, to suck the air in through our mouths down into our lungs. Well, when that diaphragm's flat and our lungs are hyperinflated, it makes it more difficult. The diaphragm has very few places to go, and then we have to use our upper chest wall muscles to open up, cause that pressure changes to get air into the lungs. Emphysema is a slow progressing disease, so someone might have it developing for 20 years and not have any symptoms or not really notice it until they hit their 50s or 60s or even their 70s. Chronic bronchitis is another form of COPD. This is a cough issue, so a lot more secretions, there's inflammation, there's infection, a lot of bad things are happening in the lungs. Whereas emphysema, you can think about that as being more of a dry disease. There's not a lot of coughing with secretions, it's more of an irritation, whereas bronchitis is a lot more of a productive cough with secretions. And I always like this slide because it points out the fact that we have secretions coming out of the lungs in chronic bronchitis. And what it does, it creates a very opportune environment for infection to take place, leading to further damage. Management of COPD, emphysema, or bronchitis, typically in the acute stages, it's about decreasing inflammation, getting antibiotics on board, oxygen therapy, allowing the person to recover. A big issue for us is the loss of function. Because they have a decrease in function, because they typically end up in bed for days on end, there's a loss of aerobic capacity, muscle strength, impacting activity and impacting participation, and making a big difference in people's lives. And this is really what we can do as where we come in as physical therapists to help. Long-term medical management, again, this is meant to be a review with you. I'm not going to go through all of these with you, but smoking cessation is the big one that can really make a long-term impact on our patients. The goal of, and I should go back here, medications, I'll just touch on that, oxygen therapy, and a little surgery. Overall, the goal is, what are we treating? If we think about a person with COPDs, there's nothing we can do to, as physical therapists, is to make these lungs smaller. We can't magically make the lungs smaller back to their size, nor can we go into here, into the alveoli, and push them back to their normal state and somehow give them back that elasticity. That's impossible for us to do as physical therapists. What we are doing, though, is we're treating the person, or we're treating their movement issues. So we think about our typical patient over here, and he's not moving very well, and he's not doing his ADLs very well. With physical therapists, we're looking at what's the biggest deficit and what can we do to address that. From the medical model, again, typically they're not going to be able to reverse the damage done by lung disease, but it's about managing the secretions, decreasing the risk of infection, keeping flow rates high as possible with medication, and really preventing an infection happening that's going to really injure the person or even take their life. Smoking cessation, remember we have the 5 A's that we work with our patients, and if they struggle through those, we can go to the 5 R's of smoking cessation. I'm not going to tell you what those are. You can look those up again and review it that way. And then medications, we have bronchodilators, which will improve airflow, corticosteroids, which will help decrease inflammation, and then this is where prevention comes in with vaccines. Pretty good evidence that vaccines are important for our patients with lung disease. And then oxygen therapy. If for some reason normal breathing is not getting oxygen to the person that they need, we can use oxygen therapy to increase their PaO2s and SaO2s. So that is your review of COPD. Remember, this is a chronic disease. This is an irreversible disease. Emphysema and bronchitis. Emphysema tends to be more of a flow issue and hyperinflation. Really not many secretions, whereas bronchitis, damage to the lungs due to repeated infections, a lot of secretions taking place. Acute management is about treating the symptoms, getting the person medically stable. Long-term management, we can't reverse the conditions, but we can treat the symptoms and decrease the risk for future problems. So there's your overview of COPD.